Professor of Vascular Surgery at the University of Glasgow, and Nick is Chair of Cardiology and Consultant at the University of Edinburgh. We've obviously had a fantastic session this morning, and I will shut the door shortly, but we'll just let some late people come in, as I'm sure there's still people to come in. Please do come in, don't worry, come on. You're welcome. Yeah, you're welcome, you're absolutely welcome. We've heard a lot about what data and AI can do and is beginning to do, and its potential in terms of early detection and of disease, diagnosis, prediction of effectiveness and outcomes. And we're keen to learn more about the practicalities of doing data-driven research and that relation to AI in the coming session, building on from the very successful exemplars that we heard in the previous ones. So obviously we heard a lot about equity and trust, and obviously Scotland's AI strategy aims to enable trustworthy, ethical and inclusive AI, and I'm sure our speakers will be talking about how they've addressed that in their talks. I'll hand over to Nick.
Okay, thank you. Well, I enjoyed this morning's session, but I prefer people talking about data to actually show you some data and to kind of get into the results. So I'm looking forward to this session more, because we'll get into some interesting observations from across Scotland, I think, using routinely collected data. We're going to start the session with a team from Dundee, 2 speakers, if I understand correctly. So Erum Masood and Gordon Milligan. And this is a talk about one of the challenges we have, which is how we use common data models to ensure that we can share data across regional areas of Scotland and with the rest of the world. So I'm really looking forward to hearing about how you've managed to successfully achieve that. And then we have some separate sessions about cardiac and respiratory medicine, and then a really interesting talk about how we use NLP from Edinburgh to try and make unstructured data available for this sort of research without compromising confidentiality, which is a really tough challenge. So we shall carry on. We have 15 minutes for each of the speakers, which includes the time for questions, so we will keep you to time. So Erum and Gordon, do you want to come up and give us the first session?
Some space.
It's a 12:30 start.
Hi, I'm Gordon Milligan. I'm Deputy Director of the Alleviate Pain Data Hub, based at the Health Informatics Centre in Dundee. Erum Masood is data engineer, also working there. We've worked together on sort of OMOP data for about 3 years. The subject of the talk today is mapping the Scottish population scale health data to the OMOP common data model to support FAIR principles. I'm here sort of standing in for Carol Morris because it's PHS work. We're splitting it between the two of us, but Carol is somewhere else. So I'm here for Carol. Carol works at PHS. She is head of data modelling there. She has given me a couple of slides from PHS, which I will cover to the best of my ability, but I'm not from PHS, so hopefully I do them justice. So I shall cover the overall project. So this work was under the banner of the CoConnect project. It was, the PIs were Professor Emily Jefferson, Dr. Phil Quinnan from University of Nottingham, Professor Sir Aziz Sheikh, I have to get the order correct for that one, and also Susan Hopkins. The aim of the project was to transform the UK's COVID-19 response by making COVID-19 related datasets findable, accessible, interruptible and reusable. So the idea was that we were trying to break down data silos that were sort of springing up with all the different datasets and research projects that were coming along for COVID to address the pandemic, and trying to get as much of that data standardised and sort of more easily discoverable to sort of aid with the pandemic. It involved a number of organisations, so it was co-led by University of Nottingham, Dundee and University of Edinburgh. Public Health Scotland was one of our biggest partners and the first big partner that did large-scale data transformation into the OMOP standard, and obviously HDR UK were a big part of that project from the start. There was also about another 20 different organisations that were involved in the project, covering about 44 different data sets. So it was we were trying to do a lot at the time. So this is Carol's slides. So the background to Public Health Scotland actually kicked in around the same time as the pandemic. It's accountable to the Scottish Government and local government. And some of the issues that Scotland suffers in terms of health is poor mental health well-being, health inequalities, drug-related deaths, and also poverty and reductions in funding for public services increasingly impacting on our health and how long we are living for. And I've bolded a lot. The bottom one was, I think this was the real impetus for PHS getting involved with us, was new and emerging diseases like COVID-19 and climate change are threatening health across the globe. So PHS got on board with us very early on. And their purpose is to prevent disease, prolong healthy life, and to promote health. Obviously, a big part of PHS is that they are trying to support research in Scotland, which is why they're involved with us. University of Dundee is one of the regional safe havens, so PHS is working in regional safe havens, working with people like RDS and HDR at the strategic level. And they also have EDRIS themselves, where they have the TRE for secure access to data, for analysis, and giving people access to actually do research and improve health issues for people of Scotland. I'm going to hand over to Erum, who's going to cover the technical aspects of the OMOP mapping process.
Thank you. Hi, I'm Erum, and in this part of the presentation, I'll cover 3 core aspects of data standards. So it's data standardization, standardization of code of practice, and how data standardization can significantly facilitate FAIR principles. So data standards are rules which encapsulate anything related to data. It could be standards for IG, how the data is manipulated, how it's stored. This data standard in the slide was created particularly for the legacy CoConnect project, but now it's been adopted a bit on a wider scope, including the PHS data standardization. On the left-hand side, it shows the building blocks of data transformation to OMOP, CDM, which is the Observational Medical Outcomes Partnership Common Data Model. It's an open community data standard, which is designed to standardize the structure of the data, which is the schema, and the contents of the data, so which could be text, numeric, alphanumeric, could be ICD-10 codes, read codes, whatever is available in the health or clinical data. And the data types, unit and Myers. And on the right side, we have the standard for the code of practice. So this code of practice is basically the standard that is defined to standardize other processes such as pseudonymization of the data and the process flow of the data. So standard code of practice is really important. We needed to make sure that a standard procedure is followed during the whole process to make sure that we validate the data transformation. And also, it helps reduce error when multiple people and organizations are involved in the data transformation to a common data model. This is a high-level overview of the methodology that we have adopted to transform the data to OMOP CDM. It's a 3-step semi-automated data transformation methodology, which means that we are also using tools to automate some of the processes. These tools were in-house developed during the legacy CoConnect project. However, a lot of development has taken place since then. We have incorporated new design and methodology in the tools to tackle big data and big data transformation, especially when it came to PHS data transformation. So the first step on the side is the pre-processing. So this uses all our code of practice for pseudonymization of IDs, how we are going to cleanse and reshape and validate the source data. And then the source data is transformed to a CSV file. We use an open source tool called Whiterabbit to extract the metadata of the source data. And then using the in-house tool called Carrot Mapper, we develop mappings from the metadata. So these mappings could be created automatically as well as manually. If the data is in an international coding scheme, then all the mappings are defined in the OMOP CDM vocabulary tables, which makes it easier. But if the data is free text or if local codings are in the data, then we have the facility to manually map it. So once the data is mapped, we have a JSON file, which is basically, you can think of it as an instruction manual. So this instruction manual tells us how the data will be restructured, how the terminologies will be standardized. Using this instruction manual in conjunction with the CSV file, we use another tool, which is the Carrot CDM, to transform the data to OMOP CDM. Now, this whole process was created with certain codes of practice we had in mind. We wanted to ensure that all the transformation can be securely done on a data partner secure network. And also, the transformation bit that involves Carrot CDM is so automated that a person who is transforming the data does not need any prior information of the data, does not need to be savvy about OMOP CDM or the mappings, and it can be run again and again on the data without these prerequisite information, which makes sure that it's run smoothly and in a standard fashion every time the data is transformed. So this data standardization actually enabled Public Health Scotland to collaborate on multiple projects, including CoConnect and wider scope projects of HDR. There is a cohort discovery tool that HDR created, which basically is built on the OMOP CDM standard, and it allows the researchers to query the data without actually accessing the data and find cohorts that could answer their research questions. And also, this will pave way for the researchers to share their analytics codes without accessing the data. It's interoperable, so you can, if you have some analytics that are reproducible or comparable with other data sets that are standardized on OMOP CDM, you can use those with other research teams and share your results. So these are the results till now for Public Health Scotland. We have successfully transformed the COVID data sets, the PCR tests, the serology data, all the COVID-19 vaccination data, and deaths that happened 2020 and onwards. So as you can see that we've mapped millions of records and millions of individuals using our process to transform data to OMOP CDM. We have also successfully mapped the outpatient, acute inpatient, cancer registry, and prescription data sets as well. The future works involve that the data sets that have been mapped be successfully transformed, and Public Health Scotland is also looking to widen the scope of these data sets, so include more data sets so they could be accessible via different platforms that support OMOP CDM. We are also in the process of transforming the SHARE registry under the Alleviate pain discovery platform data hub. This is a data hub that basically aims to bring together all the pain or pain-related research cohorts and standardize them and make them findable for the research community across the UK. And This data hub will also be working on the OMOP CDM data standards. So, yeah. Thank you.
Okay, thank you for that very nice presentation. While the experts in White Rabbit and Carrot Mapping in the audience have a wee think, I've got some basic questions for you. This sounds like a lot of work. You've managed to do it for COVID. How many people did you have on that? How long did it take? How long would it take to, is it feasible to scale that up and do it for all conditions for Public Health Scotland?
Do you want to answer? Okay.
Cover it.
Okay. So yes, it looks scary because it's a lot of data. But the beauty of this methodology is that once you've done all the hard work, then it's easy peasy. You've mapped your data, like I mentioned in the last step, the transformation. Any person who's running the transformation wants that, and you only map data once. Or maybe after a few years when you have new codes in the data set. So once the mapping is done, the transformation could be automated. It could be run by someone manually as well with no prior knowledge of all these things. And
But say I'm interested in heart attacks and not COVID. Can you get to that?
So if that information is in the data set, it will be mapped. So all the other data sets that we have mapped, if the conditions, all the conditions that exist in the data set will be mapped as well. The only data that will not be mapped may be because it's not available or that's not in scope, but that's another issue. But otherwise, you can map anything clinical using the OMOP CDM standard.
Okay, and how many people on the team?
That's a good question. How many people are on the team? Probably close to, so probably about 15 or so, I think, during the pandemic. But because the beauty of the PHS stuff was we developed these software tools, and the scale of data from PHS obviously threw up lots of issues because of the scale of PHS data, which is the beauty of working with PHS. It was actually good to work with, and Carol Morris and her team were really supportive. So it allowed us to refine these tools and be able to get up to scale. So that was a great thing, which everybody will benefit going forward. But furthermore, the mapping tool that Erum talked about, because of the way the rules work, you can actually see the rules that have been mapped from before, so you can actually reuse existing mapping. So the more mappings you get, the smoother the process will get, because you'll be able to map it in the same way and reuse them. So, it all sort of, as time goes on, it benefits from the work that was before it to actually improve things and make it easier.
Well, thank you very much. It sounds like an incredible amount of work and a really important initiative. Well done. We're going to draw the questions to a close to keep us on track.
Okay.
Thank you.
Excellent.
Thank you.
Thank you very much. Can I ask Dimitrios Doudesis to come up? Thank you, Dimitrios, who is a senior data scientist, Centre for Cardiovascular Science, University of Edinburgh, who's going to be talking about heart diagnosis of myocardial infarction and in the emergency department. So if you just press down. Okay. Thank you very much.
Well, hello everybody. I would like to start by saying thank you for giving me the opportunity to present our work here today. My name is Dimitrios Doudesis and I'm Senior Data Science at the University of Edinburgh. So the decision support tool that I'm going to present to you today has been recently been published in Nature Medicine, and it's the culmination of 10 years of research in cardiac troponin, and actually it involved collaboration with researchers from 7 countries around the world. But first, before we talk about implementation, I would like to provide some context in terms of describing to you what is the current challenges in clinical practice, the methodological approach, and seeing some data around what we have developed, the impact this could have in practice, and then the steps required towards implementation. So what are the major challenges in practice today? We all know that chest pain is the most common presentation to the emergency department in the United Kingdom, with over 1 million visits each year to the emergency department. This accounts for 5% of all unplanned hospital admission. However, only 1 in 10 of those patients actually have myocardial infarction, or as commonly known, heart attack. Now, the assessment of this patient causes considerable anxiety and also costs to the NHS an estimated £1 billion each year. But like, what are the current limitations? So the national and international guidelines recommend fixed cardiac troponin threshold for the assessment of patients with suspected acute coronary syndrome. However, these approaches rely on thresholds that do not acknowledge that cardiac troponin is a continuous measure that varies within individuals. As a result, performance varies in important patient groups as concentrations are influenced by age, makes sense, sex, and comorbidities. So we thought to address this limitation by using machine learning. And although we have published extensively on cardiac troponin threshold, in practice, all thresholds are a compromise. Lower threshold can improve sensitivity, but with a cost of specificity when it comes for the diagnosis of myocardial infarction. But even that, if we could optimize the threshold for both, we could never optimize the threshold that could work for everybody because we're all different. So the task cannot be done. So the diagnostic performance of troponin is completely different if you're in your 30s compared to if you're in your 90s, while it also varies considerably in all the major subgroups, including sex. Furthermore, 1 in 3 patients presents within 3 hours of symptoms onset using in the hospital, which is a good thing. But using today's pathways, all these patients required a serial measurement in order to make a diagnosis. Now, that results into unnecessary serial testing and, of course, and unnecessary hospital admissions. Finally, current guidelines recommend pathways that they use rigid serial measurement criteria that are inflexible and maybe they're not being followed that precisely to a very busy and overcrowded emergency department. So we aim to determine if with machine learning we overcome these challenges. So therefore we designed the CoDCS study. CoDCS stands for Collaboration and Diagnostic Evaluation of Acute Coronary Syndrome. And here we trained an extreme gradient boosting algorithm in over 10,000 consecutive patients using data from routine clinical practice. And what we did here was to incorporate cardiac troponin as a serial measurement along with clinical features and baseline characteristics of the patient that we know they are associated both with troponin and the diagnosis of myocardial infarction. Different machine learning models have been incorporated to a single decision support tool with the use of the algorithms that optimize both rule out and rule in with a single test at presentation, and of course it can be used with serial testing if that is needed. We then moved to externally validate our algorithm in more than 10,000 patients from 7 countries around the world. So CoDCS, when externally validated, I managed to achieve an excellent discrimination with an area under the curve of 0.95, while it calibrated well to the whole range of probabilities, something that is very important when you try to use a tool to the whole range and not as a specific threshold. And unlike current pathways, CoDCS provided consistent performance across the majority of subgroups, both for the rule out, this is where we send patients home and we care about safety, but also for the rule in, where we care about efficiency, and this is targeting the right population to be admitted in the hospital and to the cardiology department. So both of these, this could have the potential to reduce inequalities in care because we provide consistent performance, much more consistent performance. So CoDCS, if you imagine this as a clinical pathway, could identify 2/3 of patients at presentation with as a low probability with an excellent negative predictive value and sensitivity, including early presenters. So we don't have limitation like you presented early, we have to wait until to see if your troponin is going up or down. So we can make decisions at presentation. When it comes to ruling in, 1 of 10 patients have been identified as high probability of myocardial infarction, again with a very good positive predictive value of 75%. And in the remainder, serial testing can be obtained at any time that suits the service. So we don't have criteria or limitation that you need to take the second measurement at 2 hours, at 3 hours after the first one in order to apply a rigid delta criterion or anything. So by incorporating serial testing, again at any time point, that leaves around 13% of patients in the intermediate observed zone that they will require further testing. And finally, CodeACS does not only could improve diagnosis, reduce inequalities and inefficiency in care, but also provide excellent prediction at those that are at the risk of dying from a cardiac death in the upcoming year. Although we're not claiming that this is a prognostic tool, it's a diagnostic tool at presentation, which can provide some insights and reassuring when we're sending patients home, for example. So, how does CodeACS compares with the current standard of care? So in the UK, we have the NICE guidelines, we have the high stakes pathway in the Erum. And in Europe, we have the ESC algorithms. But how does CodeACS compare with these approaches? First, we had recently demonstrated that the performance of CodeACS remains the same and excellent no matter the time that you incorporate the serial measurement. So here we can see that at presentation with only one test, or by incorporating a serial measurement 1 hour, or the same population after 2 hours, performance remains the same, because one of the most important features in CodeACS is the troponin rate of change that allows us to calculate how troponin is going to increase no matter the time between the two samples. And as I said, when we compare CodeACS with the ESC algorithms and the high stakes pathway where Professor Mills developed and implemented, we can see that at presentation, CodeACS which was much more effective by ruling out twice as many patients with a simple test, achieving the same and similar safety with both the recommended algorithms in Europe and what we have implemented in Scotland. Now, about implementation, it definitely doesn't look like that. It's quite rainy, like Scotland, but sometimes and towards the end of the road, we hope that it will look like that. So we want to be optimistic and have that in mind. Now, for the next few slides, I'm going to talk about, of course, our experience towards implementation, but please treat that as like a casual discussion in terms of what we thought we should know earlier, what we think it's more important to focus. And this is a very simplistic visualization of what we have done and what we want to do. So first, we have developed a prototype that the link can be found both in the publication and towards the end of the slides I have a QR code, so you can have your smartphone ready if you want to scan it. And this prototype allows us to actually visualize what we want to do and to be used as a first example of how a decision support tool could look like and be able to play around with our phones without worrying about implementation, UK CE marking, all this kind of stuff. Next, we have to deploy this as a clinical dashboard, and again, this is something that no one can do alone. It is a very complex process that involves the researchers, involves NHS Scotland and Health Innovation, involves our current collaborator, StormID, and their product Linux platform, which will then allow us to implement this not only in Scotland, but again, we know this is not straightforward, this is a very simplistic approach to the whole UK and NHS. Again, a very minor, I would say, but the most difficult thing to achieve is the UK CE marking, which again sounds quite like as a tick box, but is far away from a tick box. Now, in order to implement our tool, we had to we thought to create three work streams. And again, this is very important because even if we try to implement this tool into practice now, this will be useless in the next 5 or 10 years because things change all the time. So you need 3 pillars. You need data and access, you need a modeling technique, and you need to co-design things with the end user and your collaborators. So currently we're in the user testing phase, something that was quite difficult if you were asking us 1 year ago, and hopefully this will allow us to move to the next phase, which will be implementation. I showed you about modeling in the previous slide, so I'm going to talk about the other 2 pillars now. So for data and data access, we were very grateful to have DataLoch as a collaborator that enable us to not only set the heart disease registry, which involves information from 110,000 consecutive unique patients with consecutive admission, but also in the future and currently, I'm going to explain what I mean now, it will allow you to retrain your algorithm. So after we developed CodeCS, we used the Abbott troponin I assay, and the moment we published it, NHS Lothian decided to change from troponin I to troponin T. That was a great thing, but that's okay. Every obstacle is fine. We will overcome that, and this is what we did with the help again of DataLoch, and the power of using routine collective data is to now retrain the algorithm to be used with troponin T as well. So something that was a challenge, now it's an advantage of CodeCS that can be used for both troponin assays. And of course, some of you, probably all of you know about DataLoch, but this is not only a tool a service that we use. You're welcome to use it and for your own research, of course. And next, and again, it's much more complicated than it looks like here. We're just trying to visualize how the pipeline of data works like now in the hospital. So we have a patient that they present to the hospital with suspected ACS, and the idea is to first collect and gather all their clinical information from the hospital presentation. That means like current heart rate, blood pressure, the ECG that the clinicians are doing in the hospital. Of course, with their electronic health records, like from primary care data, their previous comorbidities. Of course, with lab results, like we're going to measure troponin and all this other kind of information. So first we're bringing all this together. Again, sounds straightforward, it's not. And then through a secure API, we send all this information for this particular patient to our AI model, which is stored in a secure cloud environment. We compute the individualized probability for this patient, and then we return this again with an API and present this information to the clinician through a clinical dashboard. In our case, it's called Linux platform. It's provided from our collaborator, Storm ID. So then the clinician, with all this information in front of them, they can make the diagnosis. So we don't make the diagnosis, we assist with the diagnosis. We provide all this information grouped, and we hope to augment the decision. And this is a screenshot. This is how our platform looks like, not final, but in quite final stage. You will notice that the format is quite similar to what the NHS is used, and they're working right now. But again, my other big, I'd say, tip, I'm probably the least qualified person to talk about these things, is that to involve the end user. So if we were a business, we want our product to be used at the end. So if you're creating a smartphone, you want to take people feedback and incorporate this to your smartphone. So before we spend a lot of money, time, effort, and give something to the end user, which in this case are emergency department consultant, nurses, consultant cardiologists, junior doctors, everybody, we had to take into account what they want to see, how they want this to be presented, and of course, not everybody will agree, but it's important to involve all these people before you actually develop the product. Otherwise, you will end up with an AI decision support tool that's implemented, UK CE mark that nobody uses or trusts. So it's important to involve all these people in the development phase. And finally, yes?
You're running out of time slightly.
Sorry, yeah.
Okay, so
Sorry.
if you won't have any time for questions.
Sorry.
It's not a shame, because I'm sure there's lots of people in the room
Okay.
trying to ask you questions.
I will skip this slide. I will leave the QR code, and I will welcome any questions.
Okay, just one, I'm afraid.
I'm sorry.
I'll open up to the floor. Does anybody have a question? Yeah, please go ahead.
It's a great project. Question around your reference standard when you're developing these algorithms, particularly when the judgment of the reference standard is probably going to involve a variable, in other words, troponin. How do you approach that in terms of your ground truth to develop your algorithms when they're potentially linked?
Yeah, so you mean about the diagnosis, the label that the algorithm was trained on? What do you mean about the gold standard? Because we have different terminology.
Well, both aspects. You've got to train a diagnostic test against a reference standard. So what is the generic approach to that?
Okay.
When your test includes part of the reference standard in terms of how people are judging it.
Yeah, okay, I got it, and I completely agree with you. So first, when we developed, when we were selecting the variables, we wanted to find simple, objective, and readily available variables that we're going to incorporate to the algorithm. So if somebody has a prior belief that this might be a heart attack or not, we try to avoid including this information. And when it came to the diagnosis, again, because troponin is how it's used to make the diagnosis, we used adjudicated diagnosis. So we had a panel of expert clinicians that they had to access to available to the whole range of information, and they decided if there was actually a heart attack or not. Now, about the limitation of, yes, if you cannot have a myocardial infarction without myocardial injury and the threshold, yes, we're aware, but I don't think we can do something about that now, at least.
Okay, I'm sure there'll be lots more questioning about external validation and the route to market, or the route to CE marking, but I'm afraid we'll have to leave it there. But thank you very much for that.
Yeah, thank you.
Okay, super. So we've seen the road to implementation, and now we're going to move towards implementation, so a little closer to the horizon. So Professor Chris Carlin, welcome, and Chris is going to tell us about live AI-based prognostic risk prediction in chronic obstructive pulmonary disease. And I'm really looking forward to hear about it.
Yeah, no, thank you. Great to be presenting a home game, as it were, on behalf of the West of Scotland Hub Respiratory Group. It has removed my first slide, which is a little bit shame because it's the same themes, touch points. I think it's come out in the main meeting and has come out across the sessions already. Are linked in here, no, it's fine. It's one at the hospital, but it's in the rain, and there's a little bit about headwinds and heavy weather, as opposed to rainbow paths. But I think we're going to park them for today. I'm presenting for the first time interim primary objective planned results from the Dynamic AI clinical investigation, but trying to skate across everything that's gone on to hopefully provide a little bit of something for everyone with this as well. Disclosures are there. It's my job to collaborate widely and develop strategic partnerships. I have no financial stakes in any of the projects or collaborators that are involved in what I'm presenting today. COPD is big bad news. Okay, it costs and kills patients, families, the health service, the economy. And if you think of what you just heard about myocardial infarction, triple it. If you're considering respiratory disease and COPD. We started on this journey around 6 years or so ago with Innovate UK support and collaboration within SHIP to start at the end our sickest patients, because that has the quickest return and evidence accumulation, to transform the care pathway towards virtual models, towards remote management, and layer in digital tools and digital transformation along the way. More than 750 patients now in the West of Scotland are now comprehensively remote managed with structured data, patient app, asynchronous messaging, and where it's needed, connected home ventilation therapies, and that underpins some of the work that we're doing. We're layering other technologies in, but we have to evaluate that core proposition and show that it's worth it, and to then be able to layer something on top of that. We have a number of evaluation domains, and this, if you like, is more to illustrate our template for evaluation of new technologies within West of Scotland Innovation Hub. I'll call out equality and the ability of digital transformation to offset some of the access challenges that we face, as long as we're careful to co-design and to maintain that public involvement as we go. You can link that small QR code to some of these if of interest. There's lots of capability, lots of involvement of lots of expertise along the way that has got us to where we're at with implementation, but I'm calling out two aspects of our safe haven. Firstly, the availability of that data and provision of that routine clinical data, de-identified but linkable in cloud, to allow the models to be trained and internally validated, to bring them into the clinical space ready for use. And then secondly, to provide that data and consenting participants to hydrate inference the models in live clinical care. And that is the capability that we now have in the West and have across Scotland. These slides are placeholders, essentially, illustrate the depth and the breadth of activity that's gone on to develop meaningful, actionable, fair explainable models for some of the key COPD outcomes, 12-month mortality, the 3-month readmission rate, to try and risk profile and transform care layered on top of our digital transformation. Around this, we crafted a clinical investigation with a relatively simple set of primary objectives: acceptability, patient consent, feasibility, how many patients get a model score, and then safety, any issues as we go. But then some of our secondary objectives are where we get into that sort of sandbox. What actually do we do with these models within our MDT? How do we use them? How do we then adapt as we go? Lots of time in co-design and PPI work with colleagues at University of Glasgow to say, what do patients want to know about this, what needs to be there, and all of the resources that we've gathered for that are on our website, and you can then link with that as well. This is a frail, unwell group of patients. We need to provide consent opportunities as widely as possible. So a fully end-to-end approved consent process within the patient application that we're using in routine clinical care. We don't need to meet any of these patients to allow them to participate in the study. Again, a reusable resource. A very detailed model approval process. Every single bullet point on that slide that you shouldn't be able to read the text on is checked by engineers, data scientists, clinicians before a model gets to go live in front of a patient. And then if the model is updated, refreshed with new data and so forth, then it goes through another loop of model approval process. Idiot clinicians stepping into the data science space, so please ignore me if I've overstepped this as well. This is some of the power of it. If we look here, this is our 3-month readmission model. If we take our probability threshold at 25%, 0.25, this is the number of patients that we would miss, but also the negative and positive predictive values. If that's a light touch intervention, a check-in message through the patient app, then perhaps we can do that. If that's a heavier intervention, a secondary care face-to-face review, then we're not going to be able to find everyone, and we can't bring too many patients accidentally forward. So we have to take our threshold otherwise, and that's one of the, if you like, the powers of using these AI models. Also, we can look at some of the parameters and offset some of those inequalities. So within the model approvals, a number of fairness metrics. Called out one of the models and just shown at a higher scale here. This model is performant across the SIMD deciles. So no imbalance when looking at patients from different backgrounds. We're looking here at its performance across a number of different metrics, and there's no impact to seasonality, which removes that clinician skew, winter, COPD, exacerbation, breathless patient must be COPD, and so forth. Again, some of the power, as well as some of the work that's going on behind the scenes before it gets in front of a patient live. This is what you see on the dashboard. It's really simple. A lot of hard work by lots of collaborators to get us to this point. This was the dashboard of the first cohort of patients who consented over the first week, and you can see that the large number of those patients are showing a low risk score for 12-month mortality. These patients are probably okay, they're probably safe. We don't need to potentially undertake a review on them. But let's take a dive into the patient who scored high risk on that, and this is then what we see on that patient's dashboard with that risk score present as a percentage rather than as a binary, and then a number of features from their routine clinical data which are driving or offsetting that risk score. And if we look at item 4, as I've zoomed in there, respiratory failure. So we discussed that with that patient's MDT. We haven't seen this guy actually in secondary care for a couple of years, other than when he had admission to a hospital out with our area with decompensated respiratory failure. Message through the patient app, schedule, actually it was a short inpatient review for elective reassessment, commence NIV, evidence-based intervention, optimised, winter-proofed. That's where we're going with this. And that's the stories that we'll tell out of the secondary objectives. PowerPoint has skewed some of the words here of it as well, but this is the first planned interim evaluation after it's the first 5 months approximately of recruitment. High uptake consenting to the trial involvement from participants who've responded. 97% of participants who we tried to fire model scores had them. The 3% who didn't, it was information governance, because they live at the boundary between health boards. No safety issues, no high-risk scores related to intervention that wasn't clinically indicated, or low-risk score led to us missing something that we should otherwise have noticed. That continues to be monitored. The trial will continue for a further 12 months minimum to then undertake that clinical calibration, what do the model scores say to what outcome, and continue to generate scores across that time period and gather this rich experience with use of these models in live clinical practice. But I can show you a little bit of what this looks like by taking a look back. So the patients who were in our original receiver trial, which was the adoption of that patient app, the model has never seen their data. We'd kept them back. So this is one of our patients, and this is her timeline, and the red boxes within that are hospital admissions related to COPD, and some of those blue interventions are where we are now. That line in the sand was where we met her in respiratory medicine here and commenced her on home non-invasive ventilation, and she's now self-managing exacerbations out in the community. These are our model scores plotted over that same time period. The red dots are our 3-month readmission risk score, and they were high and provided a call to action and a feature set, including respiratory failure, 6 years before we saw her. The intervention that she was started on in 2019 was clinically indicated in 2013. You can see that her mortality risk score, the purple line, is now offset as those interventions have changed the shape of that patient's data and has changed her trajectory. The model doesn't know that we've landed that intervention because it's just routine clinical EHR data that's going into it, which is why her readmission score stays high. So we've got lots to learn still and lots to justify what data we now start to bring in to improve the performance and the actionable insights that we get from these models. Take it back to the patient side. This is Pat. Pat actually is the patient whose timeline you've just seen. I spoke to her yesterday and she says hello. And she's relatively world famous because her story, as she tells it, is at front of NHS GGC's digital strategy. Okay, this is where we are going as an organisation, within NRS, within West of Scotland, within GGC and across Scotland, and what we can do. If you do nothing else from my talk, please take the link to that video and hear some of what she has to say about how important this is and what it can be done and why this is just the tip of the iceberg. Thank you.
Super presentation, Chris. Questions from the audience while people are thinking. I think what you've achieved, partnering with external organisations, getting patients on board, deploying a virtual patient management system is really impressive. I'm particularly interested in how you're going to use the modelling to change the course here. Modeling's very good at predicting people who aren't going to survive, and it's usually because they're very elderly, and you sometimes can't prevent that happening. But avoiding hospital admissions is really important for the health service, and I think dovetails nicely with what you're trying to do. What are the greatest predictors of reattendance and hospital admission in COPD? I suspect they're similar to other chronic conditions, but do you have a sense of what is driving those high predictions?
They are similar to other conditions, and some of them are systematic and unaddressable, not actionable. They are things that you would know or would expect, but there are actionable insights. Perhaps if we take this a little bit earlier in that patient journey. So if we validate this and learn what we do with these, let's take it back to the earlier stage, take it back to the diagnostic pathway. Let's stratify the patients who are at highest risk across that as well, and tier their management so that they go onto that enhanced rate of monitoring, or have insights from their data, the long-term conditions that they otherwise have along with it. The cardiovascular risk for these patients is substantial and unaddressed, and there are easy wins in there, highlightable from their laboratory, their prescribing, or from their imaging, ancillary findings as we start to bring some of that in as well. So if I take one answer to your question, it's to take what we learn from this high resolution, heavy burden side of the pathway and stretch that back towards diagnosis.
Brilliant. We've got time for questions, so.
Hi, I'm Christina Boyle. I'm a pharmacist here in GGC. I've heard about this project before, which I think is remarkable. I was keen to find out a little bit more, and just tapping into the conversations earlier. From your experience with working with this, what are the main barriers towards patients not taking the advantage of this new technology?
Sure. I suspect we might have been nearer 95% with our uptake with the app if it hadn't been for some of the ChatGPT launch and the sort of narrative that there is around that as well. I think we have lots of work still to do to understand what public's or patients, citizens, concerns are around this and offset them address them. So I think my best answer a little bit to that is to say I don't know, and I think we need to take that conversation out. Some of it is access just basic to technology, but I can't take iPads and give them to patients unless I know the tech works first, and then it's going to change the outcome to justify that as well. So some of that comes back to policy, to resource, and to justifications for to further bridge the digital divide. I think. Hope that answers.
Thanks, Chris. In the row behind first.
Just to pick up on that a little bit more, in terms of obviously huge benefits for patients, and if you can have that earlier intervention and they see that benefit, if you're able to more and more kind of predict mortality scores and risk, where does that sit? How do you share that with the patient? How much do you share? Where does that sit within the record? Because that's obviously then a difficult.
Sure. Very strong message back from the patient group, and that was generic PPIE advisory group and from our own cohort of patients, and it's been reflected by some partner organisations down south. Have all the data. Yes, please have the model scores. Why aren't you doing this already? Coming back to patients, we don't want to see those scores. Okay, we want trusted feedback from clinicians that we know that we can see. Working with our data, we don't want to have that unvarnished appearing in our patient app. That's the strong message so far. That may change over time. We that's a discussion to continue.
Dimitrios, you had your hand up.
Yeah. How do you manage to work around regulations? Have you secured the KC marking, or I want to know everything?
I suspect you and I have a long conversation to have above the back of this as well. Yeah. This is a regulated, sponsored clinical investigation of an investigational medical device, sponsored by GGC. It is.
As in house?
No. The technology is Linus Health. They are the manufacturer of the medical device, and we have REC and MHRA note of no contention to undertake the clinical investigation, which will gather information for future regulatory approval. Linus is a self-certified Class 1 medical device, so the kind of core service aspects of that are, fully approved, QMS, and are managed through our standard e-health governance processes.
Thank you.
Very good. We'll draw that to a close. Thank you, Chris.
Thank you.
Thank you very much, Chris. Last but not least is Arlene Casey, Research Fellow from the University of Edinburgh. Welcome. Who's going to speak about understanding privacy risk in electronic health records to improve access to unstructured data, which is very difficult, without compromising confidentiality. So looking to learn more. Thank you.
Thank you. So I've got this shift before lunch. I know you're all keen to get off, so I'll try not to dwell over my time. So yeah, I'm going to talk about understanding privacy risk in electronic health records with the aim to improve access to unstructured data, but without compromising confidentiality. So this has been a collaboration across the regional safe havens and the national safe haven and our academic partners there, and it's been funded by DARE UK and Research Data Scotland. So we reckon that something like 70 to 80% of health data is unstructured, but its use in research is very limited. Usually research uses structured data. And just to be clear, when I say unstructured data, I mean data that health professionals have typed up. I got into trouble with this recently talking to one of my mum's friends. I realised she thought I was talking about GP text that GPs send you on your mobile, so as long as we're all on the same page. So the major barrier is that this type of data contains a lot of privacy risk, and so we have to take care of that in terms of protecting patient confidentiality before we release the data. But currently the processes to do that are quite manual and very time consuming, and therefore they can cost a lot of money as well for TREs to undertake that. So TREs, we would like to be able to, I use the TRE, Trusted Research Environment, Safe Haven interchangeably, they're both the same thing. We'd like to be able to support large scale free text release. And particularly there's a big push at the moment, as we all know, with ChatGPT and large language models. So this is about the work that we've done and the steps we've taken towards that. So we think about privacy risk in two ways. We think about explicit or direct identifiers, so those are things like your name, your date of birth, or family name, something like that. But we also think about indirect risks, and these are more implicit, so they're things that could reveal your identity, so maybe about your social circumstances or about where the medical event took place. So there's quite a bit of work on published work on direct identifiers. But often those models are not transferable because they're often done on US-based data because that's the only thing that's kind of freely available. They don't necessarily transfer into the UK. And also some of the models around about the direct identifiers, the frameworks don't exactly line up to what we would want to redact in the UK. But the indirect identifiers, there is no published work on that. And often when you ask sort of within the TRE community, what do you do about that? It's kind of, we actually just don't release those records, which of course is a big challenge for bias if you're not releasing all the records. So first off, I just wanted to touch on the work that we've done with public involvement and engagement. So we've actually had quite a big programme round about this, and this one slide I have just does it no justice, but that doesn't mean that it isn't really important. There is a report that will be available on the DataLoch website sometime soon, I think in the next couple of weeks about that. So we've done a number of deliberative workshops and also an online survey. But the thing that I really wanted to highlight, the work I'm talking about today, is that the public opinion has really influenced the way we think about risk and how we've kind of embedded that into our work. And I'll highlight some of that when I talk about the risks. So what have we done actually in exploring and understanding privacy risks in the electronic health records? So first off, talk about the direct privacy risks. So as I said, the regional safe havens and Public Health Scotland as well, we've got together, and our aim was to try and create a national standard about direct identifiers. How do we treat direct identifiers in the text, and can we agree what that framework is? So we've had a number of workshops. We've looked at the literature out there, what other people are doing. And we came up with our initial framework, and we've done a pilot study on discharge summaries and X-ray, just to kind of iron out all the kind of things that maybe we disagree on and the challenges of that. And we now moved into labelling the data, which we hope will be done by the end of this year, fingers crossed. So it means that we will have a gold labelled data set across all the 4 regional safe havens, so population data that we can then build a de-identification model on that we hope will work across the whole of Scotland. So that's just an example of some of the things that we have been thinking about as part of our framework, and we do want to make that publicly available. It's important to be able to share that with researchers, because as an NLP researcher, one of my very first questions when I get the data is, how's that data been treated? How does that influence how I'm going to build my model? So it's important that we can share. And at the moment, it's a bit of a black box for researchers in terms of what is actually done. So in terms of indirect privacy risks, so this was really an exploratory project. As I said, there isn't really an agreement about what's in there. I mean, we have an idea. But so what we wanted to do is we took a year's worth of discharge summaries from NHS Lothian. So it was discharge summaries from the 3 major hospitals. And we did some research through NLP kind of to look at it and say, well, what are the risks in here? And our approach was, so we kind of knew, hopefully I don't offend anyone by saying this, but clinicians do have a kind of repetitive nature to the way that they describe things. So we thought clustering and kind of sentence similarity. Sorry, I hope I haven't offended. Would be a good approach, and it was. And so we split the data into age ranges as well, because we noticed that actually, I mean, that makes sense because you've got different diseases across the age ranges, etc. And then we did this clustering topic modelling, and it's a kind of hierarchical clustering using SBERT, which is a BERT model. If you're interested, I can tell you more about that. But so essentially, we got all of these clusters, which we had labelled with the topics from the sentences. And then I'm afraid the process was quite manual. So we looked at all of these clusters to try and decide, well, which one of these looked risky. And from there, we then looked at the sentences, and if yes, they were risky, we then looked at the reports. So it's quite a qualitative kind of approach, quite time consuming. But it was a way to direct our attention to where the risks might be, because if you're faced with reading 89,000 reports, that's a lot of reports. So just to sort of show what the main categories were, and these I remember on top of what we would do for direct identifiers. So the first one that kind of came out was what we call unique medical events. We saw a lot of clusters about accidents that had happened to people where they've maybe lost a digit, lost a limb, been in a paragliding accident, a motorbike accident. But there was something kind of unique about them, the way they were described, that we felt it was a bit risky. It could make somebody identifiable, especially in this day and age with social media and things that have happened. The next category, probably not a surprise, was social. So this was about, your family members, things about divorce, custody. These things on their own might not make somebody identifiable, but it was one of the things that the public had sort of fed back and said, well, actually, do you really need to know that somebody's had a divorce and has a child that's 5 and 7? So that's why we kind of picked up a lot on these areas. The next one, locations and organisations. So in direct identifiers, we do remove things like addresses and town names, but these were more kind of nuanced and specific. So there's a kind of locality or a rurality to them, about things like homeless service names or something about where an event took place. So that example I've given there, falling outside the Costa Coffee onto the tram line. If you've got NHS Lothian data, you could maybe make a guess where that might have happened. The next category, mental health, we put this in its own kind of category because there's a lot of very unique information in there that could make somebody identifiable. And then obviously police and crime. So sometimes the police are called when a medical event happens, so information, and sometimes about crime that is just too sensitive. We wouldn't want to release maybe domestic violence or something. We have to be very careful of. So just to show, this is just an example, took all the records that had suicide mentioned in them and looked at the proportion across the age ranges. And what we were kind of looking at here is there's a different risk across the age categories, which is quite important to have that understanding of how the risk kind of occurs when you need to make a risk assessment. So age definitely influenced privacy risk likelihood. There is also a cumulative kind of patient effect. So even although we were looking at identifiable data, even if we didn't have the names, we could probably have linked patients together, where you've got people who frequently attend the hospital. And often where you found one risk category in a sentence, you then found a lot in a report. So some things to think about there. The other thing that we focused on is, so I said it's quite a manual process at the moment, and if you're an information governance person, what you're faced with is raw data files and a lot of counts of things that happen. And it's really, really hard to understand what is the risk in that data from kind of looking at raw information. So we came up with this idea of could we visualise privacy risk and how would that help information governance. So we've been exploring a prototype dashboard to essentially, we've kind of mocked up a data set with lots of risks in it and worked with our information governance colleagues to say, well, would this be helpful? Can you get an understanding of what risks are in the data? This is very much at a prototype kind of stage. But this is a quote that came back from one of the information governance specialists who said that the cohorts will help us make proportionate risk-based decision, which I think is really important if we want to move towards faster release of this type of data. And we have also gone through a full design process with this. So although this is just a dashboard with visualizations, behind it we've got a lot of design for how we would build it to a pipeline process so that we can audit trail it and how we would actually treat the risks in that. And that was another thing that came back from our work with public involvement engagement, was they wanted this audit trail of what was happening and how we treated the risk. So finally, all that's left to do is just build the models, identify the privacy risks, put it all together. Yep, sounds dead easy. But we don't underestimate how challenging that is. We've got to do the kind of, I suppose what you call the really AI bit, building the models, but actually you've got a lot of governance around about that. Even just I've said we've got labelled data in each of the regional safe havens. We're starting the discussion of how do we bring that together, because it's identifiable data. We'll have to go through each of the Caldicots to do that. But we shouldn't lose sight of the fact that we're doing this to support and promote innovative research. And I think all of us that work in research, if we can just get that bit closer to thinking about how we can implement what we build in research to the real world. And I think by making these new types of data available, sharing how we're doing that, I hope that it can be a win to just get there, a bit. So these are all our contributors, and thank you.
Thank you. Great, and we've got some time for questions. Thank you very much for an excellent talk. Before I open it up, obviously, as you said, 70% data, it's unstructured data. Have we got an automated tool for the process you described? Because it's still very manual that you have to go through.
To de-identify the data? Yeah, that's part of what we're trying to build. So there are automated tools out there, but they often don't translate into your particular type of data.
Yes.
And
so will you plan to have an automated tool built by then? This process is that one?
That's the plan. So once we get the annotated data, the next stage, that should be done at the end of the year, the next stage is to then move into building a model. And it'll be two different models, because one to deal with direct identifiers and there'll be another to deal with the indirect, which will need, I don't think we will fully automate that. There's an amount of semi-automation that will need to go on there.
Things like letters might be different from a structured report, though. So assuming that forward reports or something might be easier than others.
Yep, we know radiology already is easier. It doesn't have as many risks in it. And we have to look at each one. So we've looked at discharge summaries. Next thing, say, for example, we look at A&E admissions, might be quite different. So we need to undertake that kind of risk assessment as we look at each of them and see how well the models work.
Excellent, yes. Yeah, please go ahead.
I'm Ismail from Carlin. We also built the identification capability as part of iCare. And one of the things I'd be interested in to know what your plans are with regard to this is that having identified names in unstructured free text, basically, that you want to redact so you can make the data available for research purposes, how do you go about that redaction? So within iCare, one of the things that we did was basically to substitute all patient identifiers with credible but fake patient identifiers. And the reason we did this was to avoid, to make it actually harder for people to see if we miss.
Yeah.
And I'm just wondering, is that an approach that you're going to take, or are you going to take a different approach?
Yeah, so we've talked about that, hiding in plain sight versus redacting, and we'd actually like to do a bit of a piece of work to see what impact does that have on the downstream models. So obviously there's a real value to hiding in plain sight, because if you do miss one, it's just much less noticeable. But I think we'd like to know just what happens compared to that. And we've had discussions as well as to, if we're doing research with academic researchers hiding in plain sight, compared to, do we need to think about it differently for commercial partners? So it's...
Thank you. Andrew, do you want to?
So Andrew Morris. So terrific. So this is a privacy enhancing technology. You'll recall the ICO published a report, and this is they call it input privacy and output privacy. And in the latter, there's a sort of mathematical approach to determine indistinguishability, to actually look at the performance. So two questions. What is your mathematical approach to actually defining the effectiveness of this? And secondly, are you discussing it with the ICO?
Well, I can answer the last question quickly and say no, not at the moment. But I'm going to take from your question that you think I should be.
Well, it's an opportunity. There's a whole host of privacy enhancing technologies, and there's other things you can do. Differential privacy is when you populate your data set with dummy data to actually increase indistinguishability, which is what you're trying to do.
Mm-hmm.
So I think there's a mathematical opportunity plus a regulatory opportunity for what we do.
Yeah. So in terms of the mathematical, yes, I'm aware of it, but it's not something that we've really discussed. I think we probably should.
There's a guy in Edinburgh called Ross Anderson,
Okay.
who is a world expert on inference. So you may want to.
Excellent.
Lots of support there. Okay, Dimitri, do you want to come in?
Yes, just more of a comment, like, of course, mathematics and how to inference everything is important, but before that, the important thing is the data. So if we don't combine all the data from the different safe havens, then we will not be able to even deliver something that will be the optimal. So it's different if you train the model only on Lothian and using DataLoch data versus if you use the whole Scottish population. So it's 3 steps: data, model, and then inference, and how we're going to use probabilistic care, machine learning, NLP, etc.
Arlene, you're already working with 4 safe havens, or 5, aren't you? So do you want to answer that?
Yeah, so that is part of the reason that we're collaborating and working together. We do know that the data is different. I know that from other work that I've done, for example, with stroke phenotype, just trying to run it across the different types of data. So I think it's challenging. It's challenging to actually bring that data together. So that's the first thing. How do we get the agreement to bring it together and then develop a model that will work on all?
I think if we have the data, more people with the necessary skills will join. If you don't have the right data, then we don't have a problem to solve.
Okay, I think we're going to finish there. Thanks so much, Arlene.
Thank you
very much. It just leaves Nick and I to thank the audience for your participation and for the speakers for the excellent talks. Just shows some of the complexities that are actually facing us when we need to use big data and apply it through AI. Anything, Nick, you want to say?
No, I really enjoyed that session. It's good to see some examples of people working across Scotland and a nice diversity of output. So really well done, everyone.
Thank you very much, everybody.